Hello, Future Nurses America. Today we are going to talk about mood disorders. And the two main mood disorders we're going to speak about are major depressive disorder along with bipolar disorder. So let me share my screen. So you'll notice as we go on in class that the PowerPoints are going to be a little bit different. I will be including less on the slides. I'll be lecturing, but what you should be doing is once you get my PowerPoint is looking up some of the information, okay? So mood disorders, they are affective disorders, how we feel, and they cause a change in mood. And the four categories there are listed, but the two that we're going to focus on are your depressive disorders along with bipolar disorders. Depressive disorders, you're talking about major depression, and bipolar disorder, we're talking about bipolar 1 and 2. At this level, as ADNs, you don't really need to distinguish between bipolar 1 or 2, but I will lecture on it. You just need to know some of the symptomology, okay? So with major depressive disorder, you need 2 weeks of maladaptive functioning and must have 5 of the following. Everybody's been depressed at one time in their life, but the difference from like regular depression to major depression is it interferes with your social and occupational functioning. The first one is sleep disturbance. You're sleeping too much. I've had some patients that are sleeping 15, 20 hours a day. Two is their interest is decreased. They're not going to the sporting events. They're not going to their kids' plays. They are totally too burnt out. And because of this, they have some guilty feelings, okay? They're guilty because they're not going to work, they're not being that mom or dad, and they're not being productive. With that, the energy is significantly decreased. They're not bathing, they're not getting out of bed. And because of the constant fatigue, concentration is severely decreased. They can't concentrate how to pay the bills. They can't concentrate to go to work. A lot of times they can't drive. Appetite is variable. It can go up or down, okay? A lot of people, when they're depressed, they'll eat more, or some people won't eat at all. And just a side note, the normal average nursing student in an ADN program gains about 16 pounds over the course of 2 years in a program. What are you guys stressed or depressed about, okay? Psychomotor function, it's reduced. And I told some of you guys in clinical, I wanted you to know the difference between PMA and PMR. PMA is psychomotor agitation. You're really nervous. You're moving around, like when you're talking to a patient, they're extremely agitated. And PMR is psychomotor retardation. So people with major depression, they have psychomotor retardation. They don't move. Okay. Another disorder is dysthymia. This is what's they call depressive neurosis. And again, this is like a subtype of depression. And I know some people that are dysthymic all the time. Nothing's ever pleasing. Think of Eeyore on with Winnie the Pooh, that donkey. Nothing's ever good. Okay. And to be diagnosed with dysthymia, it's 2 years of depressed mood, more days than not. And I ask patients, you know, in a 7-day period, do you have more days when you're happy or more days when you're sad? And these patients, they'll have low energy. A lot of times they'll have insomnia or hypersomnia. They're not feeling good about themselves because they're not doing anything. Very low self-esteem because of this, okay? And you'll have some patients that will tell you they feel helpless and hopeless because they're like this. Drinking my unsweetened tea. You'll see a lot of times in the clinical site, especially if you ever read any documentation by me, I'll have a thing that's called SIG-ECAPS. So the S is sleep disturbance, up or down. I, interest decreased. G, guilty feelings because you're not providing for your children, not providing for yourself. E, energy decreased. C, concentration decreased. Appetite either goes up or down, like I said earlier. Psychomotor retardation, psychomotor function goes down. And sometimes you'll have suicidal ideations. So if you're to compare and contrast major depressive disorder versus dysthymia, people that are dysthymic normally don't think about suicide. Okay. Etiology. What does etiology mean? Where does it come from? Okay. So depressive disorders, they can be genetic. Okay. Some diseases such as diabetes can cause depression. Well, any disease you get, if somebody tells you, hey, you have cancer, yes, you're going to be depressed. Big one is first degree relatives. So if your mom, dad, sister, brother had depression, you could have depression as well. I see some people that are learned depression. They grew up in a household and they learned to be depressed. Why do you think? Because they get things. Like if you're depressed, normally people are going to help you. People are going to help you. And this ratio where it says 2 to 1, more women have depression than men. That's sort of debatable. I know one thing in my career is more females have come to me to get help than males because there's a stigma associated with asking for help. Okay. Again, etiologies, going back to etiology, genetics, hereditary, dietary. If you eat crap, you're going to feel like crap. For example, if you eat fast food, processed foods all the time, your energy level is going to be decreased, hence leading to depression. Are you all keeping up with me? Psychosocial influences as well. Learning theory, learned helplessness. We live in a society where it's very fast paced. And what happens, those of you guys that have kids, like you want them to tie their shoes or whatever, but sometimes they'll say, well, if I don't tie my shoes, my mom or dad's going to tie them anyways. So I say I can't do it. I feel helpless. Another big one is the object loss theory, result of abandonment and despair. What's happening in our world right now? More people are divorced than married. Okay. Kids are losing their parents. Look at the big one with COVID. How many parents died and kids were left alone with orphans without parents. So that's the object loss theory. Okay. We have theories about the etiology. Again, genetics, first degree relative, biochemical. Typically, if your electrolytes aren't in balance, you can be more depressed. Psychosocial, being bullied is a huge one. Back in the day, I remember when I was in school, you get in a fight with your friend, by the end of the day, it was over. Now, people bring things home, parents are getting involved, social media, it's horrific. Okay. And the last one is individual susceptibility. So again, when I was in the military, I met a lot of people that were depressed because you'd be deployed, you'd be away from your family, you go to war. A lot of service members were killed, and more people are susceptible. That's why it's very important, especially in nursing, that you don't burn out and you can learn to compartmentalize, put things in boxes, don't bring things home. You should never bring your work home, okay? So again, symptoms of depression can be apathy, sadness, sleep disturbance, as we spoke about, feeling helpless and hopeless, and a lot of guilt and anger. Why am I depressed? Why can't I do this? Why can't I provide for my family? Okay. And the other, which I touched on earlier, fatigue. You can actually get too much sleep. I have some patients that will sleep 21, 22 hours a day. They're not getting up to perform their ADLs. They're not taking showers. They're not eating. Okay. And again, dependency, they're extremely passive. Okay. And one thing that you do not want your patients to do is you do not want your patients dependent on you. Okay. So child and adolescent, do you think there's more depression with kids now than there was back, let's say 20 years ago? I would agree there is a lot more. And I think the biggest culprit or one of the biggest culprits is social media. Okay, social media. More kids are being raised in single parent households. More kids are transient. And I don't mean transient by being homeless. What I mean is moving around. Um, I grew up in a generation where the house that you were born in, you stayed in that house until you went away to college, you went to the military. Now, what we see a lot more is kids going from house to house, home to home, being raised by different family members. Okay, which can be very, very difficult for children. And again, being bullied in school is horrific. Um, I've had some patients that tell me they don't feel safe at school. And the two places that you should feel most safe is at home and at school. And if you don't feel safe in those two venues, that is when there is a problem. So geriatric considerations, okay, it's the most common disorder in the elderly. People are outliving their finances, so they become dependent, or they might have to live in poverty. Um, Bereavement overload. Does anybody know what that means? You see all people around you dying, and you think to yourself, when am I going to die? I often think about that. Like, I'll read the obituaries because when I read the paper, that's the very first thing I go to. And when I see somebody around my age dying, I think in the back of my mind, when am I going to go? Or when you have your parents die or siblings die, you think about that as well. My dad used to always go back to his high school reunion just to see who was still living. Okay. So when you're dealing with somebody with depression, you want to boost their self-esteem, and you need to accept the patient the way they are. Don't go into dealing with a patient with any kind of preconceived notions or judgments. And you want to have them focus on positive. And even when patients are in inpatient setting, okay, I tell them, you're here, you're safe. Let's collaborate. Remember collaboration, and work on this together. Okay. And again, positive feedback is very important. Just saying hi to somebody in the morning is very important. Okay. Of information. And what I mean by that is you don't want to bark a lot of orders in the morning. And one thing I always do with my patients, especially when I meet them for the first time, hey, Mr. Smith, before we start talking, can I get you something to drink? Okay. Make sure you check if they're diabetic before you give them orange juice or anything. Okay. And another thing that I do as well is I was said, it's the morning. Do you want one of the nurses to set you up so you can go and take a shower? And that way you feel fresh, and then we can talk. That's very important. Or simple washing the face or brushing the teeth, offering those services or offering the patient to do that can mean a lot to them. Okay. You want to enhance the patient's sense of personal worth because they feel like crap a lot of the time. They're in the hospital, they're away from their families, or even if they're not in the hospital and they're laying in bed all day and they're not participating with activities that they living, not being social, staying at home, losing friends, because again, people for a period of time, they'll be there to support you, but then if you're not giving back, a lot of times you can be lost. Okay. You want to work with your patients to focus on little things as well. Like you came to group today, and I'm going to just stop this just for a second. So I am back. So let me share my screen again. So again, with patients, you want to point out small things. Hey, you got up this morning, you went to group. I see you did some grooming. Okay. And when they talk negative about themselves, you want to change it into a positive. Again, patients tell me, I'm tired of being admitted into the hospital. I focus on the fact that they are safe. You're safe, Mr. Johnson. You asked for help. Let's work on this together to see if we can have some kind of agreement. What are we going to do? Maybe it's a medication change, maybe it's a therapy change. Okay. And a lot of nurses, especially new grad nurses, they have a tendency to have their patients become dependent on them. And I have this discussion every Monday when I'm working with the kids in one of the clinics that I work at, because I see this a lot more in social workers. And I tell the social workers that you're not taking this kid home with you. Your job is to help form this child to make them as independent as possible. Okay. As independent as possible. Okay. And always you want to give positive feedback. Good morning, how are you? I see you did some grooming. Thank you for attending my group. You as nursing students, you want to tell them, thank you for spending the time with me today. I learned a lot from you. Or because of you, the next time I deal with somebody that has depression or any other disease, you are better able to help them. Does everybody understand that? Okay. When you're dealing with a patient that's psychotic, you don't want to reinforce their behavior as far as if they have hallucinations or delusions. For example, they say, "Oh, I see 150 pink elephants on the wall." You want to talk about real time, real events, and you want to frame it. Mr. Smith, I don't see any pink elephants. That must be very frightening. However, you're here at Exodus and you are safe. Okay. If somebody states that they're the Queen of England, you address them by their name. You don't reinforce them by calling them Queen, because the more that you reinforce, the more they're going to believe that. Okay. You never want to argue with your patients. Okay. You want to, again, restate what they say, talk about real time, real events. Okay. And you want to state your own perception of reality. Again, I don't see pink elephants on the wall, but you appear that you're very frightened because of this. It is February 6th, 2023. This is where we're at, okay? So discuss real people and real events. Real people, real events. That is very important, okay? Anger is a difficult thing. Even when we're angry at the patient or the patient's angry at us. And there's been times in my career where I've been angry. You want to try not to show it because that breaks down all the communication. Okay. You want to know how to handle your own anger. And it's okay to walk away, take some breaths. There's sometimes that I need to leave the floor and I need to go take a walk before I deal with the patient. And I tell patients who are yelling at me, again, Mr. Smith, you appear to be extremely agitated or you feel upset about something. Can you please lower your voice? If they escalate their tone, you want to bring your tone down, okay? And it's okay to tell a patient, if you continue with this behavior, you continue to talk like this, we need to end the conversation. Now, you as nursing students on the unit, if that happens with you, what you need to do is come and get me, okay? It's okay to walk away. And it's very okay to walk away in kind of danger, okay? So we have some patients on the unit that are withdrawn and it's difficult to get them out of their rooms, okay? And sometimes it might take 10, 15, 20 times to try to encourage them, okay? I normally, the first day a patient is on the unit, I let them stay in their room, okay? Maybe they're coming down off of methamphetamine, maybe they haven't slept for a week and they need to take care of themselves. However, after that, I try to encourage them to come out. And sometimes I'll just sit next to them without saying anything, and that's called offering self, okay? And just by your presence, that might help them, okay? And you never want to go into a room with a whole bunch of students at once with one patient, because that can be overwhelming for the patient. Hey, who are these 3 people in Burgundy coming to ask me a lot of questions, okay? And I always tell the patients and the staff on the unit, if you see more than 2 students together on the unit together, I want you to throw water on them to separate them, okay? because you guys are at a point where you need to be more independent and you don't need somebody to walk you from point A to point B. And as hard as it may sound, be accepting of the patient. You need to try to be accepting as possible. If for some reason you can't tolerate a patient for some reason, and you don't feel comfortable taking that patient, you need to ask for a separate assignment, okay? Because patients can read through everything, okay? What is ambivalence? Does anybody know? Ambivalence is not knowing what you want, and I'll give you a example. When I was little, my grandmother asked me if I wanted some candy, and she had a box of candy open, and I said, "I don't care," and she goes, "Neither do I," and she closed the box, so I didn't get any candy, okay? It's very difficult dealing, in my perspective, with people that are ambivalent, so you wanna give them some choices. You never wanna ask a patient, "Do you wanna take your medication?" because they're gonna say no. How you can phrase it is medication, because that gives them some control. Because what happens, especially when you're in an inpatient unit, okay, people are telling you what time you go to bed, what time you can eat, when you can take a shower, when you can use the phone, when you can go outside. There's all these rules, and it's very controlling. So by giving the patient a little bit of control, that will help with their overall well-being, okay? Next term is cyclothymia. Think of a bicycle, okay? It's a chronic mood disturbance of 2-year duration, okay? Where you're depressed, you're manic, you're depressed, you're manic, you're depressed, you're manic, okay? So people with cyclothymia, they aren't sleeping. They're really good when they're hypomanic and they're working, because these are the type of people that will get everything done. They'll take care of all the patients, and they can only be up for so long until they crash. And once they crash, they might be in bed for 2 or 3 weeks. Okay. So people would normally, like with bipolar or cyclothymia, you will put them on mood stabilizers. And what's the 3 mood stabilizers that we discussed? Depakote, lithium, and Tegretol. Depakote therapeutic range is what? 50 to 100. Lithium therapeutic range is what? 0.6 to 1.2. And Tegretol therapeutic range is what? 8 to 12. Remember, breakfast and lunch. Next disorder is SAD, seasonal affective disorder. And our guest speaker in a few weeks will talk to you about this. And this is a subtype of depression occurring normally in late autumn or winter when things get darker. And this happens a lot in the northern hemisphere, like New York. And this is where the term snowbirds came in. My parents were snowbirds. They would live in New York during the summer, during the nice season. Then in November, December, January, February, March, they'd go to Florida because there's more sunlight and it was warmer. A lot of people in the state of Washington, they suffer from seasonal affective disorder. And if you can't afford to go away, then you can get some artificial light. And Paula, our guest speaker, will talk about how she manages her seasonal affective disorder. Next is schizoaffective disorder, and this is a 2-for-1 diagnosis. And you'll see a lot. Think about this as somebody that has the signs, the negative and positive symptoms of schizophrenia, but they also have the mood component as well. So there's schizoaffective depressed type, there's schizoaffective bipolar type, and you would treat the symptoms. Let's say they're having auditory and visual hallucinations. You can treat them with some antipsychotics, your typical or atypical. And remember, typical treat the positive symptoms, atypical treat the positive and negative. And right now, you should be able to formulate in your mind, what are the positive symptoms? What are the negative symptoms? What are the antipsychotics? What's the typical? What's the atypical? Okay. 2 more mood disorders are postpartum depression and premenstrual dysphoric disorder. Postpartum depression, again, after a woman gives birth, depressed. And I feel that males can have postpartum depression as well. It might not be from the hormonal level. It might be the fact that here you're responsible for another human being. Okay. Premenstrual dysphoric disorder. We normally treat that with hormone therapy, and this normally occurs, 2 to 3 days or up to a week prior to a female having their menses. Okay. And a lot of times when I get somebody with premenstrual dysphoric disorder and it's missed, the person that they saw might have rushed through the interview and started them right on an SSRI or a novel antidepressant. And can you guys name 3 SSRIs? Can you name 2 or 3 novel antidepressants? And remember, SSRIs and novel antidepressants, those are their first line treatment for depression. And those medications, they have side effects, but what I do when I feel that somebody has premenstrual dysphoric disorder is I will refer them to an OB so they can be placed on some hormone therapy. And one thing that we have to watch out with postpartum depression, if the decision is to have the patient go on a medication, we need to find out if they are breastfeeding, because a lot of these medications, the medications are passed through the breast milk. And if you have medications that causes sedation and the baby drinks the milk, then they're going to be sedated. Hope your minds are churning. Okay. So suicide and mood disorders. Okay. When you look at the slide, what are you thinking? Okay. Normally, the typical person that commits suicide, the older you get, the more likely you are to kill yourself, especially if you don't have protective factors. And protective factors means a support system, a stable place to live, a stable income. People that are married are less likely to kill themselves. So when you're taking ATI, you're taking the NCLEX, and they give you a little scenario, and they show you it's a white Caucasian male with no children, that would probably be the one that you would pick. Okay. And again, where it says attempt to completion ratio, there's 7 attempts for every 1 completed suicide. Okay. So you need to know these terms. SI, suicidal ideation. These are patients' thoughts about suicide. Suicidal gesture. These are non-lethal self-injurious acts. These are your attention seekers. These are patients that will come in and say, oh, I tried to kill myself. I took 2 Tylenol, or they made a little cut on their wrist. Okay. And what they try to do is use their suicidality to control the outcome. Suicidal threats. These are verbal statements. I'm going to kill myself. Okay. And again, we take all of these seriously, and the criteria, remember, for 5150, one of the criteria is danger to self. So if a patient says, I'm going to kill myself, so we need to take that. Okay. And suicidal attempt. This is the actual implementation of self-injurious act. Okay. And these are people that, they cut the wrist that requires suturing. They take a whole bottle of medication. Okay. And your typical suicidal patient, they will not talk about it. They'll just go and do it. Okay. But you take every threat as it is real. This is just a little humor. Oh my gosh, Linda, I think your Barbie's contemplating suicide because she's on the edge. So suicide themes, bereavement overload, people that get older and they're not able to function, they see their bodies failing. You'll see in high schools where one student will hurt themselves, so another student will go and try to hurt themselves as well. Depression, feeling hopeless and helpless. And one thing, especially with people with bipolar disorder, especially when they're in their manic phase, they're not thinking correctly, and they're more likely to harm themselves. So assessment, you always ask them to have a plan. The method, lethal, accessible. The method, the more effort that extends to block rescue, the greater the likelihood of successful suicide. So I have patients that are chronically suicidal. I have one patient, he states, "Hey, Dr. Brown, when I leave your office, I'm going to kill myself." Okay, how are how are you going to kill yourself? Well, I'm going to climb to the top of Mount Everest and jump. This guy lives in a box, so he's not getting there. If someone has the method of saying, "I'm going to shoot myself in the head," you want to find out if they have access to a gun. Access to a gun. Okay. And if somebody's placed on a 5150, they can't own a firearm for more for 5 years. So that right of owning a firearm is taken away. And there's been twice in my career where a police officer has been placed on a 5150 and brought into the ER, and we had to file paperwork. And what happened with one police officer, he ended up losing his job because as a police officer, you have to have a weapon. The other police officer that came in, he ended up fighting the case, and he got his right to own a firearm back. So really dealing with somebody that's suicidal, it can be difficult, but again, you have to have their best interest in mind. Best interest in mind. Okay. So precautions we take on the unit: the windows are locked, they're plexiglass, they're not glass. You'll see in the patient's bathrooms that the emergency cords are probably 2 or 3 inches long, so they can't strangle themselves. When they can't have belts, matches, cigarettes. They can shave, but it's 1-to-1, so staff has to watch them. When they have relatives coming for, we have to watch them as well. Okay. They can't bring purses on the unit or anything that can cause injury. So some precautions that you want to take. Okay. So again, on the unit, if you ever have a patient tell you that they're suicidal, you need to come and get me. So we'll assess the lethality on the unit. They don't have access to a lot. Okay. You ask direct questions. Are you feeling like killing yourself? Okay. While you're on the unit, if you have these thoughts, do you feel comfortable speaking to me? Okay. You want to provide for safety, Q 15-minute checks, a lot of times 1-to-1. On our unit, they're Q 10-minute checks. You guys as students are not allowed to do the 10-minute checks, okay? Supervised 24 hours a day. And where it says suicidal contract, that's more of a verbal thing. Mr. Smith, if you have thoughts of wanting to hurt yourself, do you feel comfortable speaking with me or speaking to somebody else on the unit? Okay. And you'll see if something gets lost. We will do a contraband search to make sure that we find it. We had one student that lost his notebook, and it was a spiral notebook, so a patient could actually take that out and kill themselves with it. So the unit was like shut down until we found that. And where it says denial of rights. So if a patient states that they're going to kill themselves, we might put them in a gown. They can't have their own clothing. They're on constant watch. They might not be able to utilize utensils, and that's called denial of rights, and that is a physician's order. Okay. Same thing if a patient states, "I plan on jumping off the building." We're not going to let them go outside for patio breaks, so we'll do a denial of rights for that. Okay. Wow. Have you guys learned anything from my lecture yet? Don't worry, you only have about 13 more slides. Okay. So for treating somebody with depression, and you'll see a term probably somewhere, vegetative depression, which is very severe depression. We can use ECT, electroconvulsive therapy. Okay. Medications we talked about, mood stabilizers, SSRIs, atypical antidepressants. I normally SSRIs and novel antidepressants, and a lot of therapy. And what I want you to know is psychotherapy along with medication management breeds the best outcome. But a lot of times people don't respond to medications. So their physician can order ECT, and this is done in an operating room. Okay. And what happens is electric shock is delivered to the brain through electrodes. Okay. And it induces a grand mal seizure. So let's say your brain's supposed to, all your neurotransmitters are supposed to come together like this, and for some reason they're shifted. This is just a dramatization. Well, when they're shocked, they go back together, so it aligns them. Okay, and I've seen this type of therapy work wonders for patients. I had a patient that was at Cedars, and this is when I first started working at Trade Tech, and the students would go there. And this patient was about 6'3", weighed about 80 pounds, so he was like a skeleton. He had a feeding tube and everything. Well, he had ECT, had about 12 sessions, was in the hospital for about a month, gained 40 or 50 pounds, and was discharged. I've seen him in the community, and he's graduated from college, so it is a great service. I have 2 patients that are in my outpatient practice that each October they come back and they get a jump start and they're fine. Okay. So indications for somebody to get ECT, this is a severely depressed patient who hasn't responded to medications. These are patients that are high risk for suicide, starvation, okay, and overwhelming depression with delusions or hallucinations. And again, when you're dealing with somebody that's delusional or has hallucinations, you talk about real events, real time. You make sure that they understand that they're safe, okay? You do not feed into their delusions. And I often get asked by patients and families and nursing students, how many sessions do they need? We don't know, okay? Initially, it's 2 to 3 times a week. Can be up to a month or 2 of duration. The hardest thing with ECT is getting it approved by insurance, but then again, I've seen wonders. I've seen this happen really well. So ECT, it's done in an operating room, normally with a psychiatrist and anesthesiologist. And you're preparing the patient just like you prepare them for any type of surgery. You have a checklist, and the biggest side effect of ECT is temporary amnesia. I've taken care of patients for months and months and months. They go and have this procedure, they come back and they don't know who I am. But that will slowly come back, okay? NPO status, and never, never, never take anybody's word for NPO. I mean, other staff members. So if a CNA comes back and tells you, oh, they said they've been NPO for 8 hours, make sure that you ask them that question, okay? When's the last time you ate or drank anything, okay? And again, since it's surgery, they have to remove dentures, jewelry, undergarments, and whatever medication is ordered, you give it, okay? So after the procedure, okay, you want to provide orientation at the time, place, who you are. Because can you imagine going into a room and not knowing anybody? You can be really scared. As I said, temporary memory loss, you assess their vital signs. Don't focus on the procedure, focus more on what's going on. Okay, Mr. Smith, we're going back to our room. We're here at Exodus. We don't do ECT at Exodus, but I'm just using that as an example, okay? So the long-term goal of ECT is to decrease depression and positive self-concept and realistic perception of self. So I told you a lot of these patients that are majorly depressed, they have no self-esteem, they haven't been working. So you want to get them to a functional level, okay? And this is just a little slide for depression, how you can monitor. And remember, when you're doing your mental status exam, let's go back to mood. I'm jumping around a little. But you determine somebody's mood, you ask them, their affect is what they see. So if someone says, hey, I'm depressed, and they look really sad, their affect is congruent with their mood. So bipolar disorder. There's a lot of artsy people that are bipolar, okay? And a lot of these artsy people, they don't like to take their medication because they say it dulls them. It dulls them, okay? So bipolar 1 is the syndrome of manic symptoms, and where they up and down, manic, depressed. And bipolar 2, they're more of a depressed patient. And at this level, as a ADN nurse, just focus on the overall term of bipolar. So when somebody's acutely manic, and we've had a few on the unit, even since you've been there, their mood is very high. They're irritable, angry, and a lot of times they're labile, where they'll be calm right now, but then they'll be really excited later. And the problem with acute mania is these people aren't sleeping, okay? They're on the go. And you might want to give them a little bit of some assignments like, here, let's wipe down all the door handles. Let's organize the food trays, give them a task. What you don't want to do is engage them in any kind of competition, because that can trigger the mania. Okay. So you wouldn't want to have like a ping pong game with them or a basketball game. You want to do something simple. Another thing is you want to keep their stimulus down. You would not have these patients right next to the nurse's station because there's a lot of noise. You would not put this person in another room with the same type of patient, because two patients feeding off each other, you wouldn't want that, okay? And this is side when they're manic, they're up, and they're depressed, they're down. So what do you need to do? How do you deal with these patients? Okay. Reduce the stimuli, quiet room, maybe darken a little. High calories, high protein. Finger foods are good so they can pick them up and take them on the go. And you want to encourage non-competitive activities, like I stated. So you don't want to play basketball or ping pong. Maybe a quiet game, some relaxing music, that would be good. And you want to assist them with hygiene, because a lot of these patients, a lot of times, they're just on the go, 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 go. And again, we treat them with mood stabilizers, okay? Remember the Tegretol, Depakote, and lithium. To bring them down, we can do Zyprexa, which is an atypical antipsychotic, okay? There's a variety of medications, okay? You don't want to rush these patients because that can trigger a mania, okay? If they're angry and irritable, maybe take them for a walk. Go outside on the patio. Of course, you need staff's permission to do that. And give them little activities to do, whether it's clean the game room, walk around, pick up the food trays, things of that nature. Okay. So you want to administer medications. So these medications: lithium, Depakote, Tegretol, Zyprexa, Klonopin, Ativan, Clozaril, Risperdal, Seroquel, Neurontin, Lamictal, and Topamax. You've all heard these medications before. So lithium is a mood stabilizer. Depakote's a mood stabilizer. So is Tegretol. Zyprexa, atypical antipsychotic. Klonopin and Ativan, they're benzos. Clozaril, remember, the mother of all mothers. Risperdal, what are the two adverse effects that you don't want to see? One is in female, one is male. The female is amenorrhea. The male is gynecomastia. Seroquel, maximum dose of Seroquel in a 24-hour period is how much? That's 800. Neurontin is a good medication. It's used for pain. It's also used for neuropathy. It's really good for mood stabilization. Lamictal is another mood stabilizer, but with Lamictal, you have to watch out for Stevens-Johnson syndrome. That's the fatal rash. So if somebody's taking it, you want to ask them, have you had any rashes? Can I see? And Topamax, mood stabilization. Okay. So you want to assess the response to medications. And again, those are the 3 mood stabilizers. And this is the last slide. You're probably saying, good God, is this over? So the interventions with somebody's manic, you want to instruct patient. So you want to set limits on the patient, okay, on their behavior. Because just because somebody has a psychiatric disorder doesn't give them the permission to be a jerk. So instructions should be clear and concise. You don't want to give them too much, too fast. Like, don't tell them 3 things at once. Give them one thing to do and go from there. Keep them on a schedule, okay? Let them know that you're not judging them, okay? Maintain a distance for your safety and for theirs. And one thing that wasn't on these slides, but people that are in mania, they're hypersexual. So whenever we get a female in, we always do an STD panel along with a pregnancy test, and males will do an STD. And you want to, educate them. If they say, "Why am I taking this medication? What's it supposed to do?" You, as the nurse, are responsible for asking them if they're having any side effects. Okay. And bipolar, we probably know someone in our life that's bipolar. Okay. We just have to, again, love and accept them. When you talk to our guest speaker in a few weeks, she'll tell you a lot more. I know this is week 1, but your midterm will be in, 4 weeks. And your midterm is based a lot on bipolar disorder and schizophrenia as well. So I hope you learned something. I would continue to do your chapter reviews, look this information up, and you have a great night.